All right. One more talk this morning. We're going to finish it off strong before lunch. You guys doing okay? Yeah? Raise your hand if you fell asleep. I like it. Got a few laughs. All right. So up next, I'm going to introduce Dr. Paolo Mimbella. Dr. Mimbella is a double board certified interventional pain physician and assistant professor in the UCSF Department of Orthopaedic Surgery. He's our newest member to the UCSF Spine Center, specializing in interventional pain medicine and rehabilitation to treat spine conditions. Dr. Mimbella's clinical expertise encompasses a wide range of interventional pain medicine techniques. Joining our outstanding and dedicated spine team at UCSF, Dr. Mimbella will be focusing on treating complex spine and musculoskeletal conditions. His research interests are centered on regenerative therapies and any minimally invasive intervention with the potential to benefit patients with both chronic and acute on chronic conditions of the spine. Dr. Mimbella's educational background is extensive and diverse, beginning both with a bachelor's and a master's of science in exercise physiology from the University of Miami, where he graduated with honors. He subsequently earned his Doctor of Medicine from St. George University in Granada. He then completed his residency training in physical medicine and rehabilitation at the University of Texas at Houston, McGovern School of Medicine, where he served as academic chief resident. This point of his medical education was followed by further specialized training as he completed a fellowship in multidisciplinary pain medicine at Montefiore Medical Center. That's a tough one, making me get into it. Affiliated with the Albert Einstein College of Medicine in New York. Please join me in welcoming Dr. Mimbella.
Thanks, appreciate it. All right, hello everyone. That was quite a mouthful. It makes it sound like I've been in training for absolute ever. Sorry, I've never used one of these before. Green arrow, perfect, thanks. All right, so I'd like to gauge a little bit, who's in the audience. How many of you work in primary care? So primary care physicians, APPs, PAs, NPs. All right, so it looks like the vast majority of you. How many of you are ATCs in the ATC space? All right, solid percentage. And then PT space, DPTs, PTAs. Anyone that I've missed? Think that basically covers it? OC Health, sorry about that. OC Health. All right. So today we are going to focus primarily on the top 5 reasons to refer to a spine specialist. I'm going to do a little bit of a spine exam demonstration, but you guys have several other lectures on just that. So the bulk of my talk will be on the main reasons that you may consider referring to a spine specialist. I have no disclosures. So the first thing that I did when I was preparing this talk is I started where I think most of us would start, with Dr. Google. It was probably where most of our patients would start. And I just asked it, like, hey, what are the top 5 reasons to refer to a spine specialist? And I don't know that Dr. Google knows how to count, so it gave me a few more than 5. So I tried to kind of clear things up and try to understand where these are coming from, how the algorithm thinks. And some of these are pretty clear-cut, maybe a diagnosis here or there, so herniated disc or spinal stenosis are diagnoses, but the rest of them are neurological symptoms. And I think the vast majority of us that work in the med space, whether it's OC Health, PT, ATC, primary care, if we see some of these symptoms, we're probably going to refer to some sort of subspecialist, whether it's ortho or physiatry or spine, et cetera. So these were pretty clear-cut. Shopping cart sign. Classic for spinal stenosis. We'll actually talk about that with an image a bit later. Then there's 3 reasons that you'd gather from a history. So the previous ones were related to symptoms, but these 3 things you'd gain from a history. So as you're talking to a patient, they're telling you how their symptoms started. whether they suffered an injury, if they had a fall, if they were in a car accident, something like that. If they're having just pain, that again, they're giving you in the history. And if the pain becomes chronic. So we'll do a quick segue. I think it's not spelled that way. So what is chronic pain? So the American Academy of Pain Medicine, they've gone to, in my opinion, painstaking lengths, no pun intended, to explain what chronic pain is. And reading through all of this, I mean, it's wonderful information. Hey, we should take a multidisciplinary approach, and I do agree with that. You know, the scientific literature shows that that's what works best with virtually any chronic pain condition. And that it's multidimensional in nature. If you're ever interested, out of University of Rochester, New York, the biopsychosocial theory on pain came out. But if there's anything to take away from this slide, it's that 3-month mark. So for some reason, you know, I guess we had to draw the line somewhere. That is where our current, I guess, philosophy of where pain goes from either acute or subacute to that chronic phase is at the 3-month mark. I still haven't really figured out what magically happens at the 12-week or 3-month mark, but I guess we really had to, you know, to be fair, we had to draw the line somewhere. And the theory is that by then, most injuries or tissues should have healed. So we talked about these familiar reasons, the historical reasons, but there's one other one that Dr. Google gave us, and that's fever. And this takes us down a different avenue. So when a patient has new onset fever with new onset back pain, it's basically infectious until, you know, otherwise proven. And this image is to give us a bit of a visual representation of different structures that can be affected with, you know, an infectious process in the spine. So it can be in the bone, in which case it's osteomyelitis. We're talking about the spine, so vertebral osteomyelitis. It can be in the disc itself, which would be a discitis. Or the infection can be in the epidural space or some of the soft tissues there. Now, this is a medical emergency. So if you suspect this, I wouldn't even go the usual routes of referring outpatient. I wouldn't even go the route of referring to an outpatient spine specialist urgently. I would send the patient directly to the ER. Again, this is a medical emergency until proven otherwise. And there's many different reasons somebody can have, you know, in most cases, you may have a low-grade fever, there's a viral syndrome along with onset back pain, but you really want to play it a little bit safe if it's brand new back pain, brand new fever, especially high-grade fever, because this can lead to some significant morbidity and potentially even mortality. As you all are well aware, the spinal meninges are there in the spine as well, the meningeal layers, and those contract directly to the brain, leading to cerebral meningitis, which again is life-threatening. So I tried to refine those 9 or so reasons to refer to a spine specialist so that it's a little bit easier to digest. And I'll give you 5 reasons. So one is persistent, and we'll go through these, you know, in detail, but persistent or worsening pain despite conservative treatment. So if you are treating conservatively, it's just not getting better, that's a good reason to refer to a spine specialist. If the patient has neurological symptoms, and some of these Dr. Google gave us, you know, referred pain pattern, weakness, those symptoms are another reason to refer to a spine specialist. If you yourself suspect that there is a structural abnormality or some mechanical issue that may require surgery, that's another good reason to send to a spine specialist. The next one goes a little bit hand in hand, but it's not exactly the same as number 3, and that's tumors or infection or undiagnosed or previously undiagnosed inflammatory disease. And then if you are very well versed in spine, you've seen a lot of patients with this, you've seen them go, you know, the conservative route and succeed, or conservative route fail, move on to interventional, or anywhere along that spectrum, end up, you know, going down the surgical route. If you are preparing the patient, you know, hey, you know what, I know these algorithms like the back of my hand, patients failed, you know, conservative treatment, you know, medications, physical modalities, physical therapy, et cetera. I want the patient to have, you know, some sort of injection, nerve block, epidural, or even surgery. Obviously, that's a really good reason to, you know, and it'll ingratiate you with your spine specialists as well. So going one by one, the persistent pain despite conservative treatment. So two of the most common reasons all pathology afflicting humanity to refer to a physician in general, or why patients seek medical care, is back pain. I think back pain is listed as the #1 reason worldwide why patients seek medical care. And if it's just not getting better, you've prescribed anti-inflammatory medications, the patient's tried over-the-counters, the patient's tried muscle relaxers, the patient has been working with a physical therapist, and many times I get referrals directly from physiotherapists who have been working with these patients. I mean, you guys are very well versed in this stuff. You've worked with these patients a lot, and you're like, this patient's not getting over this hump. They need a little something more. That's another really good reason to have the patient sent in and seen by a spine specialist. We already talked about the 12-week mark. In my opinion, the sooner the better. I personally like to get involved early. I'm not out there hunting, and several of my colleagues, we're not out there hunting for as many procedures as possible. It's really just, if we get involved early, it usually actually decreases the need for intervention. A lot of times patients just are looking for that subspecialized care, and that alone leads to better outcomes. Persistent sciatica, some of those symptoms we talked about, and then function. So if a patient is unable to do their daily tasks, they're unable to do their work, they're a dock worker or laborer, and they simply can't do what they do day to day, that's a really good reason to refer to a spine specialist. Neurological symptoms, I know we're harping on this a little bit, but anything that suggests nerve compression, nerve injury, really good reason to get them in as quick as possible. And those can be sensory, they can be motor. It doesn't necessarily have to be one or the other. Recent loss in change in coordination. That's one that I'm seeing a little bit more and more from our geriatric physicians. So a patient may use a cane, single point cane at baseline, but over the last month they've just become more unsteady. That's not necessarily presenting as your typical sciatic symptom, but that's another reason to, hey, maybe this is coming from the spine, let's get them in with a specialist. And then loss of bowel bladder control is also a red flag. I think we have a few slides on red flags as well, but that is indicative of cauda equina syndrome, which is a medical emergency. There we go. So suspected structural or mechanical issues, if the patient has a history of scoliosis, but it's getting worse, you're noticing, you see these patients in primary care, you might see them once or twice a year, you're noticing, hey, this patient's angle's getting a little bit worse, their kyphosis is getting worse. This tends to happen a lot in older age populations. If you yourself are suspecting, some of the classic reasons to send to a spine specialist, herniated discs or spinal stenosis, and definitely if you're suspecting instability, then really good reason to get in. One last point here is the compression fractures. So a patient that has brand new severe back pain, and you're gonna have to use your own clinical judgment as to what severe means, right? I'm not a huge fan of the number scale, but unfortunately it's a part of the game that we play with insurances and they require that in your documentation. But at the end of the day, for me, is this impacting the patient's quality of life? Do they think it's severe? Because some patients will tell you, hey, I'm in severe pain. Okay, can you give me a pain score? Yeah, 2 out of 10. It puts us in a little bit of a, kind of tenuous situation when we're documenting, but I'll let them know, hey, look, usually 2 to 3 is pretty low, 4 to 6 is kind of moderate, 7 to 9 is more severe. Yeah, sometimes you have to have that conversation with patients as well. But if it's affecting the patient's quality of life, to me, that requires some sort of medical care, be it conservative, be it physical modalities, physical therapy, or interventions, or even surgery. Signs of a spinal mass are tumor or infection or undiagnosed previous inflammatory disease. So some of these are red flags. Again, we talked about the fever with back pain, which is deep-seated infection until otherwise ruled out. If you have a suspicion of malignancy, and some of these can present as sudden unexplained weight loss. The patient's like, hey, I'm having all this back pain. You know what? I've also lost 30 pounds over the last month. I haven't really done anything different in my life. So that's malignancy until proven otherwise. If the patient has a history of a primary tumor and brand new back pain, that's another classic historical reason. The spine is a common place for metastatic disease. There's a lot of vascularity to the spine, and that's really the underlying pathogenesis as to how mets move to the spine. And then inflammatory conditions like ankylosing spondylitis, I do have different ranges of referring providers who will sometimes start this workup themselves. They'll do some of the room lab work to start. They'll send an ANA, they'll send HLA B27, those kinds of blood markers, and that helps with these diagnoses as well. So we've got another segue. Before we talk about the final point that we had there, let's talk about some red flags in spine. So we've got a few of them, and we'll run through them one by one. So systemic symptoms, unexplained weight loss. I apologize if I've, kind of gotten ahead of myself with some of this, but fevers and chills could indicate discitis, again, the deep-seated infection. The one point I did not mention previously here is night pain that's unrelieved by rest. So if someone's having pain that's waking them up at night, severe pain that's waking them up at night, and most mechanical issues, if you rest a little bit, they get better. But a patient that's telling you, hey, I'm going to sleep, that's when my pain gets the worst, that can indicate a malignancy. It's when metabolic activity can be a little bit higher in that region while all the rest of your metabolic activity kind of depresses a bit, and that is a symptom or potential indication of malignancy. Neurological deficits, so progressive weakness is concerning, I think, to anyone. Saddle anesthesia, we talked about cauda equina syndrome. One point about cauda equina syndrome, it is a syndrome, so it's really an assortment of symptoms. It's not necessarily of signs or symptoms. It's not necessarily a diagnosis, even though I know we have an ICD-10 code for it, but it's more a catch-all term. Bowel bladder dysfunction, often tied to cauda equina syndrome, and then ataxia and unsteady gait. This can often present just the way that the tracts within our spinal cord, the motor tracts are within our spinal cord. If someone's having significant cervical stenosis, that can present even before someone starts to have atrophy or weakness in the extremities. They're just, hey, I'm off balance. I feel off kilter. I feel like I'm on a moving boat. Or I feel like I've had, a few drinks just every day. What's going on? So that might be a place to zero in on. So if someone has a recent history of significant trauma, significant being high force trauma, so falls from a height, motor vehicle crashes, or sometimes sports related injuries where there's higher forces involved than usual, level gait. These can put you at higher risk for fracture. Minor trauma in an elderly patient, or especially someone at risk for osteoporosis, and multiple reasons why someone can be at risk for osteoporosis, is also concerning. So I've had plenty of patients that, they can't even really pinpoint when their fracture occurred, and it's found on an X-ray. And I mean, if they're at risk, so 2 or so standard deviations below their age-adjusted bone mineral density scores, so on these DEXA scans that are often done in the primary care setting, those patients can fracture even with just level car ride, go over a little bump, boom, there's a fracture at the vertebral body. Chronic corticosteroid use, so think your patients that are at high risk, transplant patients that are on lifelong immunosuppressive drugs, patients with HIV infection that are on some of these immunosuppressive drugs, or uncontrolled HIV or different kinds of chronic medications that can suppress your immune system will also put you at higher risk for bone fragility. Risk factors for malignancy. We talked about someone with a history of cancer, and we talked about how the spine is a common place for METs or metastases. Persistent pain unrelated to activity. I think we talked about the sleep time and pain worse at night. Constitutional or infection risk factors. Immunosuppression ties in here as well, so it does not just weaken your bone mineral density, but also puts you at higher risk for infectious processes. You will also gather from your patient's history if they are, for instance, I saw this unfortunately a bit when I was training in New York, but IV drug users. Patients are at very high risk for deep-seated infections. Spinal epidural abscesses and discitis being some of the soft tissue ones, and the vertebral osteomyelitis, which we saw in that image. Recent invasive procedures. So notice conceptually, it's the same thing as someone who is the same, not exactly the same thing, but it's an invasive procedure. It's a needle piercing your skin. Your skin is your barrier to the outside world. And so if that is violated, you can cause infection. There's always risk of bleeding infection with any medical procedure, venipuncture, or even more invasive procedures, epidurals, instrumentation, surgery in the spine. If someone had these recent procedures and then all of a sudden develops worsening pain in the back, neck, spine, with a fever, again, it's deep-seated infection until proven otherwise. And we talked about IV drug use. Unexplained symptoms, and so these are specific populations. Extremes of age, I was a little bit offended because I'm starting to get closer to the 50, but I didn't think that's an extreme of age. But very young patients, very older patients start to have higher susceptibilities for congenital issues, especially early on in life, or infectious and malignant issues. Thoracic spine pain. So one point about thoracic spine pain. The thoracic spine tends to be our most stable segment of the spine. It's not really a secret. It's because we have ribs there, so it's very, very stable. One concept in biomechanics, which I'm sure most of you in here are very familiar with, the more range of motion you have at a specific joint, the greater instability that you have at that joint. If you have less range of motion, that joint tends to be much more stable. So the thoracic spine cannot bend anywhere near the degree that my cervical spine can, right? Well, the advantage there is I can move my head around, but the disadvantage there is I'm going to be more susceptible to pain in my neck or dysfunction in my cervical spine than in my thoracic. And then the lumbar spine is also similar. Common conditions, I think we've covered most of these. So infection, malignancy, fractures, abscesses, and cauda equina syndrome. So I'll move on. What do you do if red flags are present? So MRI is the gold standard. The problem with MRI is it usually takes quite a bit to get in and have an MRI done. Even in emergency rooms, it's not all that common to have an MRI done emergently. It's definitely possible, and if that's what's needed, again, that's why I say, if you suspect one of these red flags, yes, put your referral into a spine specialist, but if you really suspect one of these processes, send them to the ER. They should be seen emergently, not urgently and not routine. You can start some of the workup, and it might help, if possible, depending on your setting. You can send CBCs or inflammatory markers. And if there's a high suspicion for infection, just your basic internal medicine principle of, get some blood cultures before you start any antibiotics so that, if you need to tailor your antibiotic care, you can tailor it. And then I would send also, aside from sending them to the ER, I would send an urgent referral. Hey, I've got a big suspicion for one of these red flags. It may be an infectious process, maybe a malignant process. Can you evaluate them? We'll get them in sooner. So our process at UCSF is to get them in. I don't know if it's exactly 1 week, but if it's an urgent referral, they definitely come in much quicker than routine, which can sometimes, I've seen patients waiting months for those consultations. And going back, the final one was preparation for interventional and surgical treatment. I won't harp on this because I think we've already talked about it, but if, again, you're very well versed in spine, you've seen lots of these patients, you've seen them go through, the whole pathway, and you're just like, this patient needs a medial branch block, send them in for that. This patient needs, anterior fusion, send them in for that. This patient needs an epidural, send them in for that. And you can definitely send, maybe the patient needs X, we've tried this, and this. That helps get the patient in to the right place quicker, and essentially what we're all trying to do, help that patient out as effectively as possible and efficiently. Additional considerations for referral. So trauma, we talked about the history. Basically, if you're uncertain what's going on, that's also a good reason. I saw this a lot more in the pain medicine world than in the spine world. At UCSF, I'm under the Department of Orthopaedics. I still see some of this, but hey, I don't really know what's going on here. This patient has this, unclear back pain. MRI came back. The radiologist read it as essentially clean. I'm not really seeing the patient get better with a few different medications, a few different prescriptions, different classes, some neuropathic meds, some muscle relaxer meds, some anti-inflammatory meds. They're just not getting better. That's a good reason. Send them in. We can, at the very least, help rule out a spine source. And then some patients will directly say, hey, I need to see a specialist. And, let's just keep your patients happy. I think it'll make your life a little bit easier. Who should I refer to? When we say spine specialists, who are we talking about? And so there's two big distinctions. There's either surgical or non-surgical. At UCSF, the term is non-operative spine. It's a division of spine, and operative spine, a division of spine. Within operative spine, there are essentially two surgeons qualified to perform these invasive, spine procedures. And those are neurosurgeons with fellowship in spine, and orthopedic surgeons with a fellowship training in spine as well. And so those would be your surgical colleagues to refer to if you're planning some sort of surgical intervention or evaluation for a surgical intervention. But the world that I live in, I'm a physiatrist by training, so my residency was in PM&R. Physiatrist, for those that don't know, is just, for some reason, it's the term, I used to enter this, funny story, I used to enter this in Google. I was like, physiatrist, how do you even say that? Because some people say physiatrist, and it always wanted to correct physiatrist to psychiatrist. I think over the course of maybe the last 12 months, Google no longer corrects that. So I think, the word's getting out there as to who we are and what we do. But that's our training. So our residency training is this, I call it a mishmash of internal medicine with kind of orthopedics, musculoskeletal, and neurological type patients. That's what we see. Whole lot of stroke, whole lot of spinal cord injury, brain injury, orthopedic type patients, so patients that are post-amputation, post-joint replacement. Many physiatrists subspecialize in sports medicine as well. So this is kind of the mishmash that makes PM&R its own specialty. And then within PM&R, you have those that have gone on to further subspecialize in the interventions, things like epidurals, nerve blocks, nerve ablations, some more advanced procedures, kyphoplasty, neuromodulation, spinal cord stimulation. That's a bit beyond the scope of this talk, but that's essentially who we are. So going back to what we were saying, are you thinking this is a surgical patient or a non-surgical patient? If you're thinking, hey, honestly, I don't know, probably send them non-surgical or non-op. And then we can also help determine if this is a surgical patient, and I've done that a couple of times. I've had a patient come in and I'm like, you know what, no epidural in the world, no, high level of steroid or nerve block or ablation is really gonna get you over this hump. We gotta get you in with one of my surgical colleagues. We can help make that decision as well. But if you think this patient definitely needs, laminectomy, hemilaminectomy, spinal fusion, et cetera, go ahead, please, by all means, send them to the spine surgeon. A note on surgical intervention. I have the studies cited for anybody that wants. I think they're in your handouts. I may have put them in the the presenter notes. But studies consistently show that it's a small percentage of patients with the symptoms that we talked about that end up requiring or benefiting from surgical intervention. So the vast majority of patients, I think I have a slide on this, here. So there's this funnel principle that I was taught. I was actually taught this in some of my sports medicine talks, in residency. And that is the vast majority of musculoskeletal injuries, patients don't even seek medical care. I mean, think in your own life, I've jammed my finger, I've rolled my ankle. I mean, does everybody go running to the urgent care or emergency room? Not everybody, And the vast majority of you all, if you're in this sports world, you're probably athletes/former athletes, or still like me pretending you're still an athlete. And so you try to just kind of tough through it, and eventually most of these things heal, right? Our bodies lean toward homeostasis. We have healing mechanisms in place. So that top of the funnel is those injuries. Most of that don't even seek medical care. The next step down, you seek some kind of medical care, or you ask a friend who's a medical professional, hey, what should I do here? A little bit of ice, maybe an ibuprofen for a week, and then things get better. Symptoms calm down, things heal, you move on. A smaller subset needs, prescription strength medication, needs, physical modalities, physical therapy, OC health, et cetera. A smaller subset needs these interventions, these epidurals, these nerve blocks, these ablations, and an even smaller percentage need, surgical intervention. So this is a good paradigm to put in your head as far as musculoskeletal injuries in general. So a few pearls. I wanted to talk about two big sources of spine pain. So either the disc versus the facets. And there's a couple of things to think about here. So where along the spine is the issue? So if it's a disc issue, disc herniation pushing out against a nerve, that's when you get your classic sciatic or referred pain. If it's in the neck, usually the arm. If it's in the lower back, usually down the leg. Usually single-sided, can be bilateral, depending on how severe this disc is. You won't know that until you get the MRI. But that's the typical distribution of the symptoms, the main symptom being pain, for a herniated disc. For facet arthritis, there can be a referred pain pattern. It's very well described. There's somatotopic maps that show this. But at the end of the day, you're not going to have isolated facet issues that refer to your big toe. That's just not going to happen. Keep in mind, it doesn't mean that these things exist only in isolation. You can have facet joint disease at the same time as you have disc disease. But if you're trying to tease out what is really going on here, facet versus disc, this is one place to start in your own head. Pain onset. So herniated discs typically, again, there are degenerative, slowly progressive, but typically what you get is your, 36-year-old athlete who is still trying to deadlift, 450 pounds. This is actually a personal story. And sudden onset, boom, pain in the back, shooting down that leg, shooting into the buttock. That's the usual history for somebody with a herniated nucleus pulposus. Facet arthritis or facet arthrosis or facet-mediated pain usually develops slowly over time. It's not one insult. You can't pinpoint in time. You just say, hey, you know what? My back was stiff. I've noticed it's stiff for like the last 5 years, but it just keeps getting worse and worse. The other thing to think about is aggravating factors. So with a herniated disc, if you bend forward, and I think I have an image on this. When you bend forward, you're actually putting more pressure on the anterior portion of the disc. So when you flex the spine, and most of the problem is posteriorly. So if you push more of that, just think of like a balloon. If you inflate it a little bit toward the back, and the back is where the problem is, you're going to aggravate the symptoms. Whereas with facet arthritis, it's more extension. So when you extend as opposed to flex, the symptoms get worse as you're grinding those facet joints against one another. Alleviating factors tend to be a little bit different. Notice in facet arthritis, usually if you flex forward, you're actually taking pressure off the facets. And then neurological symptoms are rare with facet arthritis. You're not going to get that, ridiculous shooting pain down the leg, down the arm, into the fingertips, into the toes. But with a herniated disc, it's a bit more classic. Here's a visual illustration of what we were talking about. So on the left side of your screen, as you flex, you can see that the facets on the back are separating, so they're not grinding against one another. Remember, these are synovial joints, so just equate in your mind like the knee. The knee is, one very big synovial joint. And so when someone has knee arthrosis, knee arthritis, it's the compressive forces, it's the grinding the femur and tibial surface against one another that really worsen that patient's knee pain. It's the same concept here in the spine. And then with the disc, I don't have to harp on that too much, but I think you guys get the picture. So a few physical exam maneuvers. These are some classic ones. You all have many lectures. Some of my colleagues are coming tomorrow to give lectures on specifically just physical examination. I strongly suggest you go to those. Those will help you tease out one diagnosis versus another. But your classic ones, I still haven't learned how to say the name of the person who invented the straight leg raise. I don't know if it's Lesegu. I think everybody in here has probably read that at some point. Somebody said it? No? I don't know how you say it. What is it?
Leseg.
Leseg? So it's Leseg? That's how you say it?
That's how I learned it.
Oh, gotcha. Okay.
Leseg.
I've heard it so many different ways, so. That's the first time I heard it that way, though. Straight leg raise test. So patient lies supine. You have the patient bring their leg up to anywhere between 30 and 70 degrees. Good, thank you. 30 and 70 degrees, and that will trigger their shooting radicular pain. That is a positive straight leg raise. Cross straight leg raise is exactly the same symptoms, but they're triggered with the opposite leg. I've seen it called the reverse straight leg raise. Sperling's test. What you do is you ask the patient, so extend your cervical spine, rotate and laterally bend. And what you are doing, I don't have a model here, but what you are doing is you're trying to get the foramen where the spinal nerve lives to decrease in diameter. And so if you extend, rotate, and laterally bend in that direction, if there is already somewhat of a compromised space, you are further compromising it. If you get that radicular symptom down the arm, that is a positive Sperling's. And then always, always, always do a good, both motor and sensory neurological exam. Don't just trust, manual muscle testing relies on patient effort. Sensory testing relies on patient response. They're verbally telling you, hey, I do feel this weird. I don't feel that. Oh, you're touching the lateral end of my lower leg. I don't feel that. But reflexes are completely objective. So don't neglect your objective neurological testing. Facet loading we talked about. For the sake of time, I'm going to move through a little bit. And then your diagnostic tests. As we talked about before, virtually for spine, your gold standard is MRI. Sometimes it's not possible if a patient has an older pacemaker or medical device implanted in their body or surgical clips from a long time ago. They may not even be a candidate for MRI, in which case CT, and if you need further imaging, CT myelogram would be the way to go. For facet arthritis, you can actually see this quite well on just plain films. Flexion extension will help with these as well. MRI, obviously, you can see even more. And then the other way to diagnose facet arthritis is actually with facet joint blocks or medial branch blocks. So you don't even need necessarily, if there's super high suspicion, I've done this a couple of times, depending on insurance, you can move to diagnostic facet blocks before you even get some of your advanced imaging. So, talked about this. Sorry about that. The last thing that I'm going to really harp on here are So we looked at, if you just enter in Google top 5 reasons to refer to a spine specialist, we kind of simplified those, but I'll simplify it even further. And I underlined the words. I want you to focus on just the underlined words. These are my top 5 reasons for referring. Do you suspect that something bigger is going on? Send the patient. Is the patient simply not getting better? Send the patient. Does the patient think that they'll benefit from education from a spine specialist? Send the patient. I don't mind having these conversations with patients. That's why I got into this. Do you think the patient will benefit from some sort of intervention? Send the patient. And then if the patient asks, send the patient. Those are my top 5 reasons to refer to a spine specialist. I think we might be a little tight, but Garrison is going to join us up here. I'm going to move to the next slide because we only have a couple more minutes. When I do my physical exams, the most important thing to do, and this is what my professors taught me, is make sure you have a system in place, and your system should be inspect, put your hands on the patient, at a minimum, ask the patient to range the joint that you're testing, and then you can move to your special tests. A lot of times, like you might have this knee-jerk reaction, oh, they have lower back pain, let me do an SLR, a straight leg raise test. Straight leg raise is positive, okay, it's herniated disc. But you might be missing other stuff, so you also might be hyper-focusing on something. Or if the provocative test is negative, like, where do you go now? So just have a system in your head. So if I was examining, Garrison came, he's like, okay, I'm having a lot of lower back pain. So I won't ask you to do this for the sake of this, but I'd ask him, well, can you take off your shirt? I want to take a look. A lot of times patients, I've asked them, have you had surgery before? No. And then they take off their shirt, big surgical scar right on the lumbar spine. So that, helps, right? Patients coming from another country, I don't have any medical records. There's no imaging on this patient. So inspect, it helps. The next thing, can I have you turn to your right? Palpate. So if Garrison's telling me I'm having a lot of pain in my lower back, I want to palpate apologies for pushing here, the lumbar paraspinals. So why do I want to put my hands on? If I'm pressing here and the patient's like screaming, that hurts a lot, that's moving my differential diagnosis towards some sort of myofascial component, right? Because I cannot palpate your disc. I can palpate your paraspinals. I can palpate your QL if I push really hard. Sorry about that, Garrison. But make sure you put your hands on patients. So inspect, palpate. After that, I will ask Garrison, can I see you bend as comfortably as you can forward and show me your flexion? Good, so it'll give me an idea. I won't go over, degrees and all of that. Again, you're gonna have, you can come up, you're gonna have other lectures on what's normal for age, etc. But I'd ask him, can you bend forward? Okay, can you put your hands on your back and extend back? Good. Can I have you turn toward me? Can you reach that right hand and try to bring it as far down your leg as you can? Good. Can you come the other way? And so compare side to side, make sure you do both sides. Can I have you keep your feet right where you are, rotate your shoulders toward that wall? Excellent. Can I have you do it toward the other wall? Perfect. Come back to neutral. And so I've ran through flexion, extension, lateral bending, and rotation. Make sure you test all the dimensions of what the spine is capable of doing. And the patient will give you feedback. Hey, you know what, when I rotate, especially if I rotate and do this, that's when it really fires and it stays right there in my back. Awesome, you're starting to think, more facet, then more disc, etc. And then you'll do, can I have you sit on the table, please? Everybody's familiar with SLR and cross-leg SLR, so I'll give you a different one. This one's called the seated slump test. So for those of us in primary care, probably reminds you of like Koenig's and Brzezinski's, which are meningeal signs. Essentially what you're trying to do is you have a limited amount of tissue, but if you flex and extend that and put tension on, they're called neural tension signs. You put tension on that neural sleeve, and it reproduces a patient's radicular or shooting symptoms. That is a positive test. So let's say Garrison came in, he told me I'm having lower back pain, and it shoots down my leg, goes all the way to the top of my right foot. I said, okay, Garrison, I'm going to ask you to do something for me. The classic way, I don't do it this way, the classic way is to put your hands behind your back and flex forward. I don't want patients falling down. So I don't personally do it that way. I tell them, put your hands on your lap and then just flex forward. And then can you let your chin also hang down toward your chest? That alone might cause the symptoms. If it doesn't, and you want to go through the full test, I would go over, first I start on the non-symptomatic side. I would go here, extend his leg. Is there pain? Is it causing the symptoms, or just kind of a stretch on the back of the hamstring there? Patient will give you his feedback. What are you feeling?
Just stretch.
Just a stretch, yeah. And then let's say we go to the other side, and you don't have to bring it up. I will actually do it for him. I'll bring his leg up. If that's not enough, again, like Koenig's and Brzezinski's, bring, flex a little bit. Any pain or just a stretch?
Just a stretch.
Just a stretch, but you don't really have a herniated disc or radicular, symptoms. Good. So, but that is your seated slump test. I personally really like this one. Again, when you go to your lectures on physical exam skills, you'll see sensitivities and specificities for these tests that range widely. I mean, 20 to 80%. I remember having a conversation with one of my sports professors about this when I was still in residency. I said, why is that? Well, most of that is inter-tester reliability. So there is super low inter-tester reliability. So my suggestion, when you come up with that system, that inspection, palpation, active range of motion, and then your provocative tests, pick and choose a few tests and become an expert at those tests. So if this is the one for you, the seated slump test, really master that seated slump. The more you do it, the better you will be at it. If it's the SLR, stick with that one. If it's the crossed SLR, stick with that one, okay? Any questions? I think we might have a minute or two for questions.
Yeah, we got more than a minute.
Oh,
we got about
beautiful.
10 minutes
Okay,
for
cool.
questions. We're not going to
Thanks,
rush it.
Appreciate you, man.
All right. So we'll start at the top. How to decide to refer to orthospine versus PM&R versus neurosurge versus pain management teams. And then a second piece of that, if no red flags, when to order imaging. Usually patients want it ASAP. And what type of images and contrast do you want to do before you see the patient?
So there's a lot to that question. I think there's like 5 parts to that question.
Yeah,
So,
it took me a lot to read.
I'll start with, at UCSF, at least that question is a little bit easy. The ortho spine surgeons and physiatrists, we work in the same department. And so we're part of, if you're close to Parnassus, we're part of the integrated spine service. We actually work in the exact same clinical space. It's wonderful. I've worked with, Dr. Bervin, Dr. Tay, several of the other surgeons there, hand in hand. Hey, what do you think of this case? I'm thinking potentially surgery. So if you have that resource available to you, send to an integrated spine center, because the integrated spine center, you're sending to a place that has all of those resources, the surgical and the non-surgical approaches. Personally, thinking of that funnel we were talking about, I would start with non-op first. But there may be a little internal bias there. Full disclosure, I'm a non-op spine specialist. Unless you really think, or you had an imaging of, patient was, you're probably not going to see this in outpatient, but anything's possible. Patient was in a car wreck, you did some imaging, the radiologist calls you and says, hey, there's instability, bilateral pars fractures at C6-7. This patient should be immobilized. In that case, I don't even think you're going to refer to us. You're going to send them straight to the ER. You're probably going to call the ambulance, get them collared, and send them to the ER. Why? Because if there's instability, you could lead to a spinal cord injury there. So it's the same principle from emergency care. If somebody has a fall, or you're not supposed to manipulate that person. You're supposed to, you have to let first the professionals, the EMTs and first responders kind of get their board and collar patients. That's why we board and collar patients. But I think that might answer the first question. When it comes to neurosurgery, essentially neurosurgery spine, ortho spine, no offense to one or the other, I'm sure somebody's going to get offended. For all intents and purposes for spine, equivalent when it comes to these surgical interventions. You may want to ask an ortho spine surgeon or a neurospine surgeon what they think. They can give you their opinion. Now, the last part of the question, can you read it to me one more time?
Yeah, of course.
Imaging, I think, is what it was.
It was about with no red flags, when would you order imaging? Because usually patients want it yesterday.
Correct.
And what type of images or contrast do you want done before you see the patient?
So I remember in med school, we were always taught about resource management. And that is, hey, you know what? You should do a good history, you should do a good physical. If your patient's reasonable, which we all know that nothing in life is 100%. If your patient's reasonable and you let them know, hey, look, I've examined you, you don't have what we in medicine call, neurological red flags. I think that you can get better with a course of anti-inflammatories, maybe a muscle relaxer to help you with some of your symptoms. I'm going to get you into physiotherapy. I want them to start with just some of the passive things like TENS, ultrasound, ice and heat, and see how you do as you progress through your rehabilitation. I think most patients are receptive to that. Everyone is not. And you're going to have to use your own clinical judgment. I think my fellowship director used to call it therapeutic X-rays or therapeutic MRIs. You're going to have to make that decision. I don't know how much it helps to fight the good fight if your patient's, going to leave you a 1 out of 5 star review on Yelp and then tell everybody that you're a terrible, provider. So that's my 2 cents on that. What do I personally need? I think I talked about this on the presentation. I like to get involved early because I like seeing, call me old school, but I like seeing patients get better, and not everybody needs all these interventions. It also helps me because even from an interventional standpoint, I can let the patient know, hey, look, this is what I'm thinking, this is what it looks like is going on, this is my plan A, this is my plan B, this is my plan C. So when I see them at follow-up at 3 months, 4 months, 5 months, and they're not getting better, that conversation is easier. The patient has been prepped for months on maybe you do need an epidural, maybe you do need a medial branch block, maybe you do need an RFA. And so patients are much more receptive the earlier you get involved. So for me, I'm not going to say send me every back pain you have, but I will say if you think that the patient can benefit from my services, I'm happy, just get me involved.
I'm sending you everyone I have.
And then imaging. Imaging was the last. What do I need? I don't need necessarily the imaging, but I hope you've gathered a few of those Chihuahua pearls from this talk. And if you're seeing, not necessarily the red flags, but if you're seeing, hey, you know what, I do think that there's a herniated disc here, send them for the MRI. I mean, you've got clinical judgment as well. Trust your clinical judgment. Your gut will talk to you. And even if it's a reasonable patient, just tell them, hey, look, I want to take a closer look at what's going on here. I'm going to send you for an MRI. I'm also going to send you for a referral to the spine center. I will say the one caveat to that, and I'm part of a system. The system likes to have imaging in place, and these are my preferences. This is not everyone. I do know plenty of my colleagues that will simply not see a patient if they don't have imaging first. So I do want you guys to be aware of that. It is individual preference, okay? Surgically, I don't know virtually any surgeon that likes to see a patient that hasn't had imaging. But again, they're considering a surgical approach. They need to have some sort of, what would I operate on if I was to operate? So it makes sense. For me, I'm a physiatrist by training, and so I have not historically shot advanced imaging on absolutely everyone. And like we saw with the funnel, some patients get better without need for those resources.
All right, for acute lumbar or cervical pain with radiculopathy, what interventions and medications do you recommend for initial treatment, acknowledging PT takes time, a lot more now? Do you prescribe NSAIDs, oral steroids, gabapentin, or other options?
So one easy way that I've tackled this when I've been in different, I worked in rural Texas for a little while, and I was not having referrals. Patients would flood in off the street because, I was the only medical provider. And so with those patients, this is what I would do. If I think this patient is absolutely insanely miserable and I have a huge suspicion for a disc, I want anti-inflammation as quick as possible. That's a Medrol dose pack. As long as there's no contraindication, because keep in mind, you guys are all medical professionals. If there's a contraindication to, totally uncontrolled, diabetes or super high blood pressure, the patient's systolics, 200, you don't want to increase a catecholamine response and bring that up higher, right? So as long as there's no contraindication, put them on a Medrol dose pack, 6 or 7 days, tapering dose, and see if they get better. Let them know it's going to take a little bit of time. I always let the patient know, once you start it, you have to finish it. It's like an antibiotic course, because you can throw your hormones out of whack. That's the conversation I have with patients. Most patients, adhere pretty easily to it. So if that's your more severe, and then I'll get them in for the MRI, and then I'll start to consider interventions. If the patient's somewhere in the middle, maybe a prescription, and they tell you themselves, hey, I tried ibuprofen, I was taking 200 milligrams once a day. What exactly? That's the appropriate response. You're not doing anything. And I let the patients know, I understand they come in 200 milligram tablets, but let's put you on what my military patients would call Ranger candy, 800 milligrams of ibuprofen, twice or 3 times a day. And so try that out first. If that's not enough, there are patients that respond to certain NSAIDs and not to others. I've seen this plenty. So don't forget all your other NSAID classes. So meloxicams, naproxens, nabumetones, all of those. And so you may want to try. So you have all these tools available to you. Consider that. That's if someone's in the gray zone. Now, if somebody comes in and tells me, hey, I've been taking ibuprofen 800 8 times a day, first of all, I tell them you need to stop that. And then I tell them, let's get a quick MRI and decide what happens next. So that's usually what I'll do. And then a good cocktail, and this comes from the pain management world, a good cocktail is don't just try super high dose single pharmacology medication. It's better if you do maybe moderate dose of a couple of different. So maybe put them on a neuropathic med, either a gabapentin, Lyrica, in some cases a Cymbalta, something like that, SNRI. Add in a muscle relaxer. So you've got, baclofen, metaxalone, et cetera, several, and add in some anti-inflammation. Patients also appreciate that because you're telling them, hey, look, I'm going to put you on a bit of a cocktail. We're attacking this pain from a lot of different areas. Let's see how your body responds. And so I hope that answers that question.
Awesome. Well, we're out of time, but I'm sure I can get you to answer some more questions on the app as well for people. But thank you, Dr. Mimbella, for that great talk. Appreciate it. Thank you. All right, don't stand up yet. I know you want to go. I know. I get it. I know. All right, quick things. One, don't forget to visit the vendors outside when you guys are walking around after lunch, before lunch. They're here for us. They're here for you. They got some cool stuff. So mingle, get to know them a little bit. And then when you guys come back from lunch, again, you're going to go straight to your workshop or you're going to come here. Now, don't forget the wait list. Don't line up at the doors. Otherwise, we're going to send in somebody to bounce you out of there, right? It's not going to be me. I'm not very strong. But come here if you're on the wait list. You'll get a notification if you get into one of the other breakouts. Otherwise, enjoy the talks here. Thanks to all of our speakers this morning. Thanks to Garrison for coming up here in dress, shoes, and shorts. And you guys have a great lunch. We're going to meet back here at about 1:50, it looks like. Not back here, wherever you go. We'll see you guys there.